Welcome, sir. Over to you.
Thank you, Navneet Singhji. Dear trainees, welcome. Dr. Munita, thank you very much for accepting our invitation. Good morning and welcome to you. I know in your tight, busy schedule, you could still honor the commitment for the benefit of the students. Thank you very much. Dear trainees, in continuation with the series we had on GI Onco, this is the most important talk, the pathological evaluation in colorectal cancer. If you look back the landmark trials which came last 1 to 2 years, everything based from the pathology and then went on to the molecular pathology and NGS, which laid big grounds to MSI, MMR and NGS. More than that, best TNM classification started in colorectal and then it also got adopted in various things. So today we have a professor of pathology from TMH Mumbai, Dr. Munita, who is going to cover pathological evaluation in colorectal cancer. At the end of your talks, please put your questions in the chat box or Q&A, and Dr. Munita will try to answer after our talk in the given time. Thank you very much. Welcome, and over to you, Dr. Munita.
Good morning, everyone. Thank you, Dr. Somashekar and Dr. Saklani and Dr. Navneet for having me here today on an early morning, Saturday morning. So without much ado, I'll start with the pathology evaluation in colorectal cancer. So in this talk, I'll basically be covering the basics of pathology evaluation and try to deconstruct the information that we provide in a pathology report and cover some of the essentials as well as what we want from surgeons. The goal of pathology evaluation changes with the setting of the specimen. So it can be in the diagnostic setting. Our job is different from what when we deal with the resection specimen or when we have specimen at the metastatic setting. So in the diagnostic setting, we usually get a biopsy, and our main job is to confirm whether there is malignancy or not, and to provide the histologic type of the malignancy. And in more than 90% of the times, the malignancy is usually adenocarcinoma, which is conventional type, but not infrequently, we also get some specific histologic subtypes, which could be signet ring cell carcinoma, mucinous carcinoma, medullary carcinoma, adenosquamous, rare variants like micropapillary or hepatoid. So these are much more rare, but they generally tend to be more aggressive than the conventional adenocarcinomas. And not infrequently, we can also get a non-adenocarcinoma malignancy, and the pathologist has to be a little aware because in a poorly differentiated malignant tumor, you need to differentiate. Morphology may not be enough, and you may require immunohistochemistry to further subtype it because you can get other tumors as well. So you can get squamous carcinoma when the biopsy is from the anorectal region, and sometimes it is just labeled as rectal biopsy, and if the tumor is poorly differentiated, you may not realize that it is a squamous rather than an adenocarcinoma, so it can be mistaken for adenocarcinoma. So we need to be careful. It could be a neuroendocrine tumor, and then we have to grade it. And we can also encounter GIST or a lymphoma and a melanoma and a sarcoma. And the diagnosis is absolutely crucial for management. So we need to use appropriate immunohistochemistry to make an accurate diagnosis, because in some of the conditions, especially lymphoma, you may not require surgery, whereas in a GIST, you may just require a sleeve resection, and so on. So our job kind of changes when we deal with a resection specimen. Here, the key questions that we address. Now, the diagnosis is mostly known at this time. It should be known. And the key questions here are: is the surgery complete? What is the stage of the tumor? And are there any adverse features? And this we provide by giving you the pathologic TNM staging, the status of the margins, and also try to give you as much as possible prognostic information from the tumor to tell you whether this has an adverse biology or not, whether you need to add adjuvant or not. So before we go on to the actual evaluation, there are some basic essentials. That is, one, we need an intact specimen. So because that can interfere with If the specimen is already cut open, that can interfere with evaluation of the margins as well as assessment of serosa. So you need to resist the urge to cut the tumor and have a look at it. No matter how good the surgery is, we need a very good fixed specimen, because if the specimen is autolyzed, no amount of good surgery can save it. We cannot generate any report if the specimen is autolyzed. So each specimen needs to be sent in a 10% neutral buffered formalin fixative. No other fixative. Do not use normal saline. We still get some specimens from outside which are sent in normal saline, because some of the surgeons will feel that perhaps immunohistochemistry is required or some molecular testing is required. So this tissue should be sent, should not be formalin fixed. That is incorrect. So for every, even for molecular testing and immunohistochemistry, it's absolutely essential that the tissue that we get is properly fixed in formalin. So the best tissue is you need the formalin fixed tissue, and it should be 10 times the volume of the specimen. The fixative needs to be about 10 times the volume of the specimen. The entire specimen should be dipped into it, and half the specimen should not be jutting out of formalin, and because it gets dried up and autolyzed. Again, without this need not be mentioned, but the samples need to be labeled properly. The ink can get smudged when the specimens are wet, so these will not be accepted and they can be rejected. So unless the specimen is labeled, the patient identification, everything should be clean. Now we come to the pathology report, and when we deal with oncology specimens, we mainly follow some protocols, and most of the protocols are in alignment. We usually follow the CAP protocols or the Royal College of Pathology data sets. And these are unified with International Collaboration of Cancer Reporting, the ICCR data sets. They form our guidelines and they provide templates and basically categorize pathology information into core data items, which are absolutely essential for an oncology specimen. And additionally, there are some optional data items that can be added. These are called as the non-core data items. This is additional information that can be provided in addition to core data items. Again, before we actually start the evaluation, it's absolutely essential that we are provided the clinical data. Many times, the specimens that we get from outside sometimes have only one specimen written on the requisition form without any information. Sometimes even the age is not provided. So that is largely unacceptable, because we need to integrate the clinical information. The pathology evaluation is always in a clinical context, and this is absolutely essential that we need the demographic data, the age of the patient, the gender, the family history, if this is a patient having a hereditary tumors, or there's any family history of cancer. If this malignancy or this lesion is occurring in the setting of a Lynch syndrome or a polyposis syndrome, or patient has a history of ulcerative colitis or any inflammatory bowel disease, or patient has multiple polyps, or there are more than one tumors, those also need to be evaluated, and also whether this is occurring in a recurrent setting. And one extremely important information, which is a core data item, is whether any neoadjuvant therapy was used. Neoadjuvant therapy, and what type of therapy, what was the duration, that information needs to be provided. And the staging also changes, and also the way what happens to the tumor after neoadjuvant therapy is that it undergoes a lot of degeneration, or it can just change its appearance, and it can be totally, it may not be visible on gross examination, and we can totally miss the tumor, and then it needs to be correlated with the endoscopy data, and we need to make sure that it is completely sampled and the bed is completely sampled. So not only on gross but also on microscopy, the tumor morphology can completely change, and it can influence the interpretation. So it's important to provide this information whether neoadjuvant therapy was given or not. And the staging after neoadjuvant therapy, the DNM staging, we have a Y prefix, which indicates that this is a post-neoadjuvant staging. The type of specimen, again, is to be included as a core data item. It's absolutely essential that you provide us the information, what is the operative procedure, and extremely important that any additional tissue which is there on the specimen, that it is better it is mentioned. Please take it that sometimes, especially in a high volume center, it is the first year resident who would be many times crossing and handling and who's used to typical specimens. And if that information of any extra additional tissue that was removed on table is not mentioned on the requisition form. Sometimes the requisition forms are filled before the surgery starts, and they may not include any modification that you have done on table. It's best to include all the information, whether you've removed seminal vesicles or prostate chafe or vaginal wall or any other additional extension you have done on the specimen if it is mentioned or it is communicated to the pathologist, so that there are no so that it is not accidentally missed by the crosser and completely inked and that small bit of tissue is missed. So any additional tissue or any other new procedure which you start introducing, if you introduce a new surgery, if you start introducing suppose you have started doing extended APRs or intersphincteric resections or complete colonic mesocolic excisions, whatever modifications or new techniques you introduce which can have a bearing on the pathology evaluation, on the margin assessment, that should be communicated to the pathologist also, so that they do not, so that they are also updated and they also provide you the information that you want. Tumor site, absolutely, again, important information. And many times when the specimen is X50, it is removed, we lose orientation with respect to flexures and so on, and we may not be able to completely assess whether this is the left side colon or it is in the splenic flexion. So the tumor site should also be mentioned on the requisition form. It's important for registry, for prognostication, to include tumors in various clinical trials. The exact tumor epicenter needs to be mentioned, and we also need the relationship between whether this tumor has a non-peritonealized margin. Would be included or not. What are the regional lymph nodes, whether the nodes which are there would be regional, non-regional, that assignment also required, where the tumor epicenter is. And if there are multiple tumors, that also need to be documented and reported individually. So when we begin the examination of the specimen, the first thing that we scrutinize is the exterior aspect of the specimen, and we look for tumor perforation, because presence of any tumor perforation has an increased risk of peritoneal dissemination of the disease later on. It's an adverse prognostic factor, and it would straight away imply a stage T4, pathological T4. And if the specimen has undergone any iatrogenic perforation, then that also it's best to communicate to the pathologist that there was some tearing of the specimen, or there was any that can be indicated on the specimen with that, so that it does not interfere with interpretation. And then you can have perforation which is not tumor associated. So distal obstructive tumor can have a proximal non-tumor related perforation. That perforation is not equal to PT4. That does not upstage it, although it can be associated with a higher mortality risk. So after that, another core data item is for rectal tumors, we need to document what is the relation of the tumor to the anterior peritoneal reflection. So for rectal tumors, it's anterior peritoneal reflection is an important landmark, and you can see on the anterior surface, this is the landmark, and the information whether the tumor is at the peritoneal reflection above or below, that needs to be documented, because the relationship of the peritoneum and the bare surface will change accordingly. So the interpretation is very important. So here is the anterior peritoneal. This is the anterior surface of the rectum, and you can see this is the anterior peritoneal reflection, and we need to document whether the tumor is sitting here or it is above or below, and because this is the underneath the lower surface is the bare surface or the circumferential resection margin, and if the tumors which are at and below have a higher risk of recurrence. And this is the posterior aspect, and posteriorly you can see there is a triangular bare area which corresponds to the non-brutalized surface or corresponds to the CRM or the circumferential resection margin. So again, we have still not opened the specimen. Before opening, we also grade the plane of surgical excision for total mesorectal excision specimens. Now, TME is the gold standard for surgery for rectal cancers, and the plane of surgical excision where the dissection plane has gone through, that predicts what is the local recurrence, and it's the marker of the quality of the surgery. And this is the information that the pathology report can provide it as a feedback to the multidisciplinary team to improve the quality of surgery, and also it correlates with the outcomes with TME. So this is the gold standard, and in the total mesorectal excision, the plane of dissection should be outside the mesorectal fascia. And what we do is we assess what is the quality of the surgery or quality of the TME. So a complete TME is when we say that the plane of excision has passed outside the mesorectal fascia. So this is the mesorectal plane. Or complete TME, you can see that the mesorectal fascia is smooth. There is no violation of the mesorectal fascia. There are hardly any defects on this. There's a good bulk on the specimen, and there is no coning of the specimen. So this is a complete TME or a grade 3 TME. A nearly complete TME is when the plane of surgical dissection has passed through the mesorectal fat. So this is an intramesorectal plane, and there you can see there are some minor irregularities on the mesorectal surface. There is a moderate coning, but you don't see any muscle yet. So the muscular plane is the one. This is the one which is called as the incomplete TME. This is where you can see large defects, or you can find deep cuts and tears, and you can see that the muscle is visible, and you can find mesorectal tissue missing at places. So the CRM is formed by the muscle. So this is incomplete TME, and this muscularis propria plane of dissection, this is associated with a significant risk of local recurrence and overall recurrence. So the impact of the plane of resection may be independent of the circumferential resection. In a large meta-analysis of more than 3,000 specimens, it was seen that about 54% of them form complete mesorectal plane of dissection is complete TME is there. About 30% have a nearly complete, and 15% can have incomplete. So we should also know our data, and we should also and seek this information from the pathologist. And if your pathologist is giving almost all of them as complete TME, that also means that they have been, there is something missing, because you should make sure that they are doing this evaluation properly. This can extend to the abdominal APR specimens also. The plane of dissection can be extralevator, it can be sphincteric, or it can be intrasphincteric. So extralevator plane, in these specimens, you will find that it is external to the external sphincter and levator ani, and there is the shape of the specimen is cylindrical, and there are no significant defects in this. This will be when there is an extralevator APR. Specimens in most of the specimens will be like this. If it is not an extended resection, if the levator is not extended, cuff of levator is not removed, then most of the times it will be sphincteric plane. The plane of the surface, plane on the surface of the sphincteric muscles is there. There is no cuff of the levator, and the specimen will have a waist, a surgical waist or coning, but you don't see significant defects into the sphincteric muscles. And intrasphincteric plane is when the plane of dissection has gone within the sphincteric muscles. There can be iatrogenic defects and perforation. So this is not what we want. Similarly, now it has been shown moving on from TME, even on the colonic resections. It is still not a core data item, but if we have a complete mesocolic excisions, that can also be graded, whether the colonic resection is through the mesocolic plane, intramesocolic plane, or the muscularis propria plane. So complete mesocolic excision, in that the mesocolic plane is, you can see that it is there's a smooth surface to the mesocolon, no irregularities, and surface defects are less than 5 millimeters in depth. Whereas in the intramesocolic plane, you will start seeing these mesocolic defects, and but these are not extending to the muscularis propria. And exposure, when you start seeing the exposure to the muscularis propria, that is a muscularis plane, so that needs to be avoided. So unless we audit the plane, we would not know what we are doing. So then we finally come to the resection margins, the next very important evaluation. So as far as the colon and the colorectal specimens are concerned, they have different relationship to the peritoneum. So that also needs to be taken into account, what margins will be sampled. So some of the, so like the cecum, the transverse colon and the sigmoid colon have a mesocolon, whereas ascending and descending colon have a anteriorly peritonalized surface, and posteriorly they have a non-peritonalized surface. And rectum, we have already seen, has a unique relationship where anteriorly the rectum, the peritoneum is reflects onto the bladder or the uterus, and posteriorly it has this triangular shaped bare area. So whether this specimen has a bare area or is completely covered with peritoneum, that has a bearing on the reporting of the margins. And the resection margins that we report with respect to colorectal specimens are the longitudinal margins. Sometimes donuts are sent separately. If there is mesentery, if there's a mesocolon, then mesenteric margins, and if there is a non-peritonealized surface, then we have a circumferential resection margin. So longitudinal margins are just on-shape margins from the cut ends. These are sampled and evaluated. For mesocolon, we have the mesenteric margins where the mesocolon is cut. This is inked, and then this is the distance is measured between the tumor and the mesenteric margin. This is for transverse colon and sigmoid colon. And for the non-peritonealized, we have the circumferential resection margin, which is the bare area which has been cut out from the patient. So in the rectum, we've seen this. This is again, we need to identify how much is the bare area and what is the relationship of the tumor to the peritoneum and the non-peritonealized surface. So this is the serosa. It is seen as a shiny surface, and this, whereas the non-peritonealized surface is the bare area, and that forms the circumferential resection margin. So what we do is we examine it, and we then ink the bare area. We don't have to ink the serosa. The serosa should not be inked. Serosa can be visualized under the microscope, whereas the bare area, to be able to examine under the microscope, we need to ink it. And then the specimen is cut open, and only the part where the tumor is there, that is left intact. And then we insert some formalin soaked cotton swabs into the specimen, keep it overnight, fix it for 24 hours to 48 hours. And that enables this whole thing to become like a rigid tube, and then we are able to cut it and serially slice it. So we serially slice it and lay down all the slices on the board and examine from top to bottom. And this gives us, we examine these perfect rings, and then we are able to see, we have to examine, this is the step which is the most important, where you need to examine each slice and see where all the tumor is reaching very close to the circumferential resection margin. So this selection of the slices for ultimately histopathological evaluation is very crucial. So all the slices where the tumor is going very close to the serosal or to the CRM, these are finally picked up and evaluated. And this, you can see what it looks like under the microscope, that you have this is a tumor. And this surface, because of the ink, we can imagine, we can see it under the microscope, where the margin is. And the distance of the tumor, the deepest extent of the tumor to the CRM, that is reported as the tumor distance. And the resection margin status, these are the terms which are used. R0 for a negative margin. We call it R1 if the margin is positive on microscopy, and R2 if the margin is grossly positive. So, and on microscopy, what is called as a positive margin is the one where the tumor is within 1 millimeters of the circumferential resection margin. Tumor in any form present within 1 millimeter of the circumferential resection margin is called as a positive margin. So this is a strong predictor of local recurrence with or without neoadjuvant therapy, and also may predict distant metastasis and overall survival. Now, what causes these? There are four ways in which this margin can be positive. One is the direct involvement of the direct extension. The tumor reaches a circumferential resection margin, but sometimes you can have a lymph node at the margin which is metastatic. That is one of the sources of positive margin. And then you can have discontinuous tumor deposits, or you can have extramural venous emboli cutting right up to being cut by the at margin. So these are the different ways in which margin. So any tumor in any form present within 1 millimeter is regarded as a positive margin. And one thing when we are considering margins is that we need to remember that 5 centimeters of colon in vivo will shrink, and it is equivalent to a 3 centimeter after resection because it's a muscular organ. And after fixation itself also induces tissue shrinkage. It would lead to a 2.2 centimeters. So that is one of the studies which has shown. So there is a variable amount of shrinkage, and there is a variable amount of contracture that happens after the specimen is removed from the body. Tumor size, we need to document it as a baseline information. It does not go into the TNM staging, but the maximum dimension of the tumor needs to be entered. Then histologic typing, most of the times histologic typing is already known, but now in the resection specimen we have the full specimen, so we can see whether is it a conventional adenocarcinoma or is it a subtype. Signet ring cell adenocarcinoma we call when we see these signet ring cells. If they are more than 50% of the tumor cells show this appearance of signet rings, we call it a signet ring cell adenocarcinoma. If the tumor is full of mucin, extracellular mucin, and more than 50% of the tumor shows extracellular mucin, then it is called as a mucinous adenocarcinoma. Then we can have a medullary carcinoma, which is sheets of undifferentiated tumor cells, which are admixed with the lymphocytes. This is an immune-rich carcinoma, and is usually is a histology which is associated with MSI-high tumors. Even the mucinous tumors are also is a histology which is commonly seen in MSI-high tumors. Rarely you can see an adenosquamous carcinoma where you have dual differentiation of glandular and squamous differentiation, and other rare histologic subtypes which are associated with increased nodal metastasis and a worse outcome are micropapillary, where you see these small papillae lying in empty spaces. And rarely you can see a hepatoid adenocarcinoma, which can look like hepatocellular carcinoma and can be AFP producing also, and these are aggressive. So these are rare and aggressive subtypes, but signet ring and mucinous adenocarcinomas are something that we see much more frequently than the other subtypes. We grade the tumor based on the least differentiated component, and it can be graded into well differentiated, where you see a lot of glands, and as the tumor differentiation worsens, the gland formation decreases and tumor cells become more and more pleomorphic. So that's another important thing, that the most crucial thing that we do is provide the pathologic TNM staging. The staging is done according to AJCC 8th edition. So now we have the TNM 8 staging which we are doing, and unlike other systems where the tumor size is taken into account for tumor staging, here it is the extent of invasion into the layers of the GI tract that TNM is provided. So this is the mucosal layer, the submucosal layer, then we have the muscularis propria layer, then there is a layer of subserosa or adventitia, and a layer and which is covered with serosa. So these are the layers, and we see how much is the tumor extent through the layers of the bowel that determine the T staging. So PT1 stage is when it goes into the submucosa. PT2 is when it goes into the muscularis propria. It's a PT3 stage when it goes into the subserosa or the adventitia. And when it involves the serosa, it is called as the PT4A. And when it involves another organ through the serosa, then it is called as PT4B. So PT4A is when it is involving the serosa, and PT4B is when it involves some adjacent structure. It could be a small intestine, it could be pancreas or others. So We examine the exterior aspect, and serosal perforations mostly, or serosal involvement, is seen in the form of either the opacity or dullness or induration on the surface of the serosa, or sometimes there are serosal exudates. You don't see a frank perforation. Most of the times the serosa is covered with a thick exudate, or it is fibrotic, and these are the areas that we are dependent on the person who is examining to do a very good thorough job, so that he doesn't miss the areas which need to be sampled. Again, we also want an intact specimen. If you already open up and send, then these are areas which may be missed during examination. So T4B is the adjacent organ involvement through peritoneum, and it could also be at the in the rectal. You can have direct extraperitoneal extension. It has to be microscopically determined. Just attachment of a bowel to a small intestine, it may be fibrous adhesions, and that may not amount to T4B. So microscopic confirmation needs to be demonstrated. Intramural extension from a longitudinal spread through the wall, not through the serosa, is also not T4B. So in the rectum, tumors invading the skeletal muscle of the external sphincter or the levator ani, they are classified as T4B. So regarding the end staging, so that is the T staging. After that, we do need to do the nodal staging, also extremely crucial. Most important is how many nodes to be sampled. Every node that is present in the specimen needs to be evaluated, needs to be dissected and sampled for accurate staging. For accurate staging, a cutoff, studies have shown that a cutoff of 12, a minimum of 12 lymph nodes are required. And if the report shows less than 12 lymph nodes, then you're justified in asking your pathologist to sample more nodes. And it is also a quality indicator for pathology evaluation that the nodes should be at least 12 lymph nodes. If we get less than 12 lymph nodes, we go back to the specimen and do more extensive sampling. And very often that does lead to the adequate number of lymph nodes. If lymph nodes are less than 12, then there are good chances of that the tumor may not be staged properly, and the medical oncologist may have to give chemotherapy just because the tumor is not staged properly. So there are some factors which can affect the nodal yield. In older patients, in obese patients, patients with poor immune status, you can find lesser nodes. Right-sided specimens give more lymph nodes compared to the rectum, and the left-sided. There can be surgeon-dependent factors. There can be the pathologist-dependent factors. And very important factor, which is very commonly seen, which affects the nodal yield, is neoadjuvant therapy. If a neoadjuvant therapy is given, that definitely leads to a reduction. So radiation completely melts the lymphoid tissue, and you may find very low nodal yield in a post-neoadjuvant specimen. And low lymph node harvest is an adverse prognosticator in stage 2 disease. It also can reflect a combination of inadequate nodal retrieval and an unfavorable patient immunology. So sometimes we completely strip the whole specimen and submit it, and yet we may not find many nodes. So that situation also happens. But from the pathology point of view, at least extensive regrossing should be done if the number of lymph nodes is less. But there will be instances where you would not find lymph nodes, and that may also be because of unfavorable patient factors. So one of the crucial things that we encounter when we are dealing with lymph nodes is there are tumor deposits in the fat. So in the subserosal fat, we may find these tumor deposits where you don't find any lymphoid tissue, and you do not know whether there has been a lot of work on this and controversy on this, whether these deposits are lymph nodes or whether these have to be counted in the nodal staging, or whether these are tumor deposits and should be counted in the tumor. So these, first of all, when do we call it a tumor deposit is when we find a discrete, a separate tumor nodule, which is usually irregular. It is in the colorectal adipose tissue. In the lymphatic drainage of the primary cancer, it is discontinuous from the primary tumor. and it does not show any lymph node. So you can't see any lymphoid tissue. You don't see a capsule, lymph node capsule. You don't see it as a inside a vein. It's not an extramural venous emboli, and it is not a part of it's not a nerve deposit. So it's neither a perineural deposit, nor a vascular deposit, nor a lymphoid tissue, lymph node deposit. So when we don't see any of that, then we label this discontinuous deposit as a tumor deposit. And this is counted as in the nodal staging. So extramural tumor deposit. So this is the main tumor and a discontinuous tumor deposit. This can also be a source of margin positivity when it is present at the CRM. And this is nodal. If you don't find any lymph nodes which are positive, then this tumor deposit is counted under the lymph nodes, and it is in the end staging as N1C. So if there is a nodal metastasis is present, then we do not incorporate this into the nodal staging. So then the nodal staging will be reflected by the number of metastatic lymph nodes. But if you have all the nodes which are negative, but you have a tumor deposit, then it is regarded as N1C, and chemotherapy, adjuvant therapy is given based on that. So that is the importance of extramural tumor deposits in colorectal cancer. And it is also seen that if you the burden of these extramural tumor deposits, that also should be documented. Whether there are 5 or more than 5 tumor deposits, as the number of tumor deposits increase, they are associated with a worse outcome. So that is also an additional prognostic information that can be provided in the pathology report. So if there are too many tumor deposits, more than 5 tumor deposits, that is associated with a worse outcome. Metastasis, it's not in our purview to write about the metastasis unless we know that it has been a separately sent tissue. So M1A is when you any site without peritoneal metastasis. When you have 2 or more sites without peritoneal metastasis, that is M1B, and M1C is when you have peritoneal metastasis. And this is also important that the non-regional lymph nodes, if they are involved, that are counted in metastasis, distant metastasis. So, and if there are multiple organs which are paired, like ovaries and lungs, that is still called as N1A disease and not counted as two organ sites. So it's anyways, this is something that the clinical clinician will have information, and pathologists most of the times are not required to assign N0 stage. Again, peritoneal deposits, there is a distinction that we need to make, whether the tumor is the serosa or the peritoneum is directly involved by the tumor, that is labeled as PT4A, whereas if there is a discontinuous peritoneal deposit, a serosal deposit away from the peritoneum, from the primary tumor, that is regarded as N1C, that becomes a peritoneal disease. So that categorization is also important. Now, we have moved in the recently the T3 staging, where you have the tumor infiltrating the subserosa. Many investigators have shown that if you further subclassify how deep is the invasion into the subserosa, that is also very prognostic. So there are proposals by various authors to try and subclassify T3 into various subcategories, and one of the classification is where you say that whether the tumor is going 1 millimeter deep into the subserosa, or 1 to 15 millimeters, or more than 15 millimeters. There are many other proposals as well, but what we are moving towards is that measuring the extent of invasion of the tumor into the subserosa provides prognostic information, and it has been seen that these also provide important prognostic information, and this is something that we also have started giving out in our reports. Then is the tumor regression grade. If the specimen if the patient has received neoadjuvant therapy, then tumor can undergo regression. So in the pathology specimen, we can see variable degree of regression, and this is recorded in the form of TRG or tumor regression grade, where and it has been shown that this is an important prognostic factor for recurrence-free survival. So what response we can see is either we can see fibrosis or tumor necrosis, or we see a lot of acellular mucin. So many times post-neoadjuvant therapy specimens show a lot of abundant acellular mucin, and many times the response is also seen in the form of fibrosis. So it is this proportion of whether there is more fibrosis, more acellular mucin, or whether there is more tumor. That is what we grade and we see. This tumor regression grade is given by the assessment of the primary tumor site, and this is not graded in the lymph nodes. So the entire tumor bed needs to be examined. So many times you will see we'll see that there is no grossly identifiable tumor, only an induration is present or a scar is present, and there are times when you don't see anything, right? So that it is completely resolved. So it needs to be correlated with the endoscopy findings, the pre-operative findings, and the entire tumor bed where the tumor is supposed to be, that needs to be sampled. And in cases where we don't see an obvious growth, any induration or the area of tumor bed, complete evaluation of that is done. So only when we evaluate the post-neoadjuvant lymph nodes, you will find that in the post-neoadjuvant treatment, we find lymph nodes which show only mucin. So that is not regarded as a metastatic lymph node now. So in a post-neoadjuvant lymph node, we need to see viable tumor cells. If viable tumor cells are present, then we call it a metastatic lymph node. Necrosis, fibrosis, acellular mucin within lymph nodes in a setting where there is a neoadjuvant therapy has been given, that is not regarded as a nodal involvement. So complete. Okay, so this is a specimen which is showing this. Sometimes you will only see a puckering or a scar, and the entire tumor bed or that scar has to be evaluated for histopathologic evaluation. And you can see that here you can see that you don't see an obvious tumor, but you see large sea of fibrosis basically, and you can see only calcification. Here, this bluish spots that you can see are calcified foci, and only in this box, only this much is the residual cancer we can see. And this also shows a lot of effects of radiation. The tumor starts looking very, very ugly post neoadjuvant. So this slide basically shows you that the tumors, very scattered foci of tumor, like this small box here you can see, can be seen embedded in large areas of fibrosis. So the sampling becomes extremely crucial, that we need to sample extensively, otherwise we will miss these small foci. And this is also a problem in radiology, that these small foci embedded in fibrosis, on radiology you cannot make out whether there is tumor present in that fibrotic area or not. So this is one of the reasons that how the tumor shrinks after radiation or post-neoadjuvant. It can be in the form of a lot of fibrosis, and it can also be in the form of a lot of extracellular mucin. So there are various scoring systems. There is a Ryan system, there is Mandard, Duarte. Ryan system is adopted by the CAP. And basically what we see is whether there is more tumor left or whether there is more fibrosis, and whether there is a complete response. So if there are no viable cancer cells, that is a complete response. If there are single and small groups of cancer cells, that's moderate response, or the grade is 1. If there is a residual cancer which is outgrown by fibrosis, that is TRG grade 2 and a minimal response. If there is no tumor kill, lot of tumor, extensive residual cancer, that's a poor response, or a TRG3. So these Ryan, Duarte, and Mandard, these are all interchangeable. They look at the same factors, and you can use any of the systems. They have been compared, and most of them show, they basically look at whether there is a complete response, or whether there is more fibrosis, or whether there is more response, or there is negligible response. Complete pathological response is, we label the complete pathological response when there is complete absence of viable tumor, both in the primary tumor site as well as in the lymph nodes. So YPT0 and YPN0. So many times we will see acellular mucin alone, which means there are no tumor cells, but only extracellular mucin. And sometimes this is picked up on radiology, and it can be difficult to distinguish whether there is viable tumor or not. These are the specimens sometimes we find on resection. This may be full of acellular mucin, but it is showing no viable tumor cells. So that is equal to, that is not regarded as residual tumor. So acellular mucin alone without any viable tumor cells is not regarded as tumor. It is regarded as complete as response. So now some of the recent studies have shown that if you also tell us what is the extent of acellular mucin pools and whether acellular mucin pools are present or not, or whether they are reaching up to the CRM, that may also have an effect on the outcomes. So this I can skip for the time being, but studies have shown that the presence of acellular mucin and how deep it is going into which layer, that may also be prognostic. And some of the investigators have proposed staging based on presence of extracellular mucin. Another important, extremely important core data item that we need to provide is presence of extramural venous invasion, because if extramural venous invasion is present, it is a very adverse pathological marker of distant relapse. So what we see in the under the microscope is, here you can see an artery, and next to the artery you find that there are tumor deposits. Now the problem with venous invasion is that it can completely engulf the vein, and you may not recognize the vein when you see it under the microscope. And one of the clues of venous invasion is when you have an orphan artery. So arteries and veins, they travel together, and if you only see a single artery and you find a tumor deposit next to it, that is the biggest clue that this might be there might be extramural venous invasion. And we many times have to take help of elastic stains to identify whether these are indeed these tumor deposits are inside the vein. So orphan artery sign is something that we see, and documenting elastic vein presence of tumor emboli inside a vein is by using elastic stain may be required. And this is something that can be missed completely by the pathologist, because usually these tumor deposits completely engulf the vein, and the vein is usually not recognizable. So it's important for the pathologist to pick it up, and it is also a parameter that can be used in audits. At least more than 30% of your if your audits show that the incidence of reporting is less than 30%, that means the pathologist is missing these, reporting these. So we should actively seek out, and this is something that can be picked up on MRI, and they present like a sausage-like thickening. And if MRI shows EMVI, then you can call up your pathologist and ask him to do elastic stains or correlate with the MRI findings and see if EMVI was present. Because elastic stains help in picking up more. The rate of detection of EMVI increases when we use elastic stain, and it is recognized that it can be completely missed on simple histopathology examination. So that is important. It's a well-established independent prognostic indicator, and the pathology report should mention whether EMVI is present or not, and it's part of the quality assurance standards. And any venous spread, whether even if it is intramural, even that is also associated with adverse prognosis. Another core data item is presence of perineural invasion. That is associated in an early disease. It is associated with adverse prognostic implication. And in other sites, we tend to say whether it is intramural or extramural. Here, we do not. There is not enough data to know whether identifying whether perineural invasion outside the bowel wall, extramural or intramural, has any prognostic connotation. Another core data item is tumor budding, which is poor prognostic prognosticator. Now, what do we mean by tumor budding is when the tumor, it's a measure of basically the phenomena of epithelial mesenchymal transition. So as the tumors advance or they acquire metastatic potential, they start breaking down into smaller groups, and they start becoming discohesive, and there is more and more cellular dispersion. So the tumor, which is much more, when they are more epithelial, they are more cohesive. When they start acquiring mesenchymal properties and they start becoming more adverse, they start becoming less cohesive and they start appearing as single cells. So at the tumor advancing edge, we can see whether the tumor has started showing tumor budding, whether the tumor has started becoming more isolated as single cells. So a tumor bud is defined as a single cancer cell or a cluster of less than 5 cancer cells at the advancing edge. So at the tumor advancing edge, we can see whether the tumor is, I'm sorry, I didn't put up a picture, but basically it shows, we basically at the tumor advancing edge, we see if there are presence of any single cells or small clusters which are up to 4 cell clusters, less than 5 cancer cells, that corresponds a bud. So a single bud is that a single cell or a cluster of less than 5 cells. So there is a scoring system which is proposed by the International Tumor Budding Consensus Conference, and there is a 3-tier scoring system where we count the number of buds at the invasive end, and we see whether it is a high budding, the budding score is low, 0 to 4, budding score is intermediate, 5 to 9, or you find more than 10 buds in 10 fields. So a high tumor budding is associated with adverse prognostic factor, and this is a factor especially when we talk of early cancers. This is something which is taken into account and may be an indication for chemotherapy if you find a high tumor budding. So for mucinous and signet ring cells, which as such have single cells, for that tumor budding is not done. Even for post-neoadjuvant therapy, specimens where you may have a fragmented tumor, for that also tumor budding score is not provided. So the clinical relevance is in the early cancer, in the PT1 colorectal cancer. It basically indicates high tumor budding indicates there is an increased risk of lymph nodal metastasis, and in stage 2 it is associated with increased risk of recurrence and mortality. So tumor budding is also an important factor that now you will see in your reports. So last but not the least, microsatellite instability or the mismatch repair status. That is something that is a required item for in all colorectal cancers. The mismatch repair status should be provided. Now we know that traditionally it has been for detecting Lynch syndrome, but we know that these, even in the sporadic setting, non-germline setting also, you find that about 12 to 15% of the tumors will be MMR deficient or mismatch repair deficient, also called as MSI high tumors. These tumors which are MMR deficient, they are associated with, inherently they are associated with good prognosis. They have an indolent behavior, but they have a poor response to 5-fluorouracil-based chemotherapy. So in the stage 2 tumors, when you have MMR, based on the status of MMR, because they don't benefit with 5-fluorouracil therapy, so these tumors can be avoided, node-negative tumors can be avoided chemotherapy if you know mismatch repair status. So if there is MSI high tumors or mismatch repair deficiency is there, then you can, the response to treatment is different. And in the coming years, what has happened is that what we have seen is there high efficacy of immune checkpoint blockade in patients who have MSI high tumors. Because these MSI high tumors have a high neoadjuvant, they produce a lot of new antigens. They are very immunoresponsive. They have a high immune infiltrate, and they are very responsive to immune checkpoint inhibitors, and this is a category of tumors which shows a very good response to immune checkpoint inhibitors, and that's why recently it has become absolutely essential to also identify the MMR status or the mismatch repair status, to identify these are candidates for immunotherapy. So mismatch repair deficient tumors are responsive to immune checkpoint inhibitors. This is one of the most important, from the treatment point of view, this is an important information. So How we can do microsatellite instability or mismatch repair is by using immunohistochemistry. We can also do polymerase chain reaction, so in a molecular lab. So mismatch repair, immunohistochemistry or PCR will tell you as a screening test whether these tumors are MSI high or not. So when I refer to MSI or microsatellite instability, it is almost equivalent of mismatch repair deficiency. So when we have tumors which have mismatch repair defects, they tend to produce microsatellite instability. So these are two terms which are used interchangeably. So when tumors have mismatch repair deficiency, they also have microsatellite instability. So they are, both terms are used to reflect mismatch repair defects. So, to detect this in lab, whether the tumor has mismatch repair deficiency or is a MSI high, we do immunohistochemistry, and some of the labs will do PCR testing to detect that. Both of them show comparable performance, and both have their own advantages and disadvantages. And the false negative rate is approximately 5 to 10% and applies to both. Now, with the next generation sequencing, we can also use NGS. Now, this is something that is new, and but many labs are now starting to offer microsatellite instability testing on NGS, and the data were limited. But it appears to show that it has a good sensitivity and specificity as compared to so again, basically how these goes is that we have these 4 genes, which is MLH1, PMS2, MSH2, and MSH6. Now these are 4 primary genes which are involved in mismatch, in repair of the mismatches. So whenever there is DNA, whenever there is cellular replication, there are lots of defects that happen during the normal cell proliferation. So all these errors are corrected by DNA polymerase, and whatever are the smaller defects, these are corrected by these mismatch repair, all the mismatch repair enzymes which are encoded by these genes. So if any of this gene is not functioning, either because of the germline defect or it is because of an epigenetic silencing of the gene, that leads to mismatch repair deficiency. So those errors of replication, they are not corrected. So they remain in the DNA, and overall, these can lead to these are errors which are also seen in microsatellites. So they also lead to microsatellite instability. So that itself is a big topic on what are the basics of that. But what we see is that MLH1, PMS2, MSH2, and MSH6, these are the 4 genes which are the mismatch repair genes. Any defect in these will lead to mismatch repair defects. So on immunohistochemistry, what is again important thing is they work in pairs. So MLH1 and PMS2 work in pairs, and MSH2 and MSH6 they work in pairs. So MLH1 is the dominant partner, whereas PMS2 is a secondary partner. And when the dominant partner is not there, then the secondary partner also undergoes degradation. So if PMS2 is whereas MLH1 is not dependent on PMS2, PMS2 is dependent on MLH1. So what we look at is similar is the case for MSH2 and MSH6. So this MSH2, which is in blue, is the dominant partner, whereas MSH6 is its secondary partner. If MSH2 is not present, then MSH6, its secondary partner, also gets degraded. So if there is a loss of MSH2, what we see on immunohistochemistry, we will find that its secondary partner also is lost. So we will see in your report, you will see in the immunohistochemistry report, where we are trying to see immunohistochemistry for MLH1, PMS2, MSH2, and MSH6, we will see loss of either of the protein. But if the dominant partner is lost, then its secondary partner is also lost. So in a case where there is MLH1 loss, you will find the report will mention that there is, whereas the other partners, MSH2 and MSH6, will be intact. Whereas if the secondary partner alone is lost, then the dominant partner is still there. So PMS2 is lost, MLH1 will still be there, it will be retained. So So these MLH1 and MSH2 are the obligate partners, whereas its secondary partners, they will be lost when the primary obligate partner is not there. So this is how we interpret it. So if there is loss of MLH1, which is the dominant partner, many times we will see PMS2, its secondary partner is also lost, whereas the MSH2 and MSH6 is preserved. So if this pattern is seen of MLH1 and PMS2 loss, we interpret this as that the underlying genetic mutation would be an MLH1 mutation. Similarly, if you find MSH2 is lost as well as MSH6, its secondary partner is lost. That means the main partner MSH2 is lost and there is an MSH2 mutation. In this case, MLH1 and PMS2 are preserved. So whereas MSH6, if it is mutated, you will find that there will be loss only in MSH6. MSH2, which is its dominant partner, it is not dependent on MSH6, it will be still retained. So based on the pattern, what we see on the immunohistochemistry of these four proteins, we can find out what is the underlying mutation which is likely. So immunohistochemistry serves as a screening test to do for further confirmation by genetic tests. So the caveats of this is that you can get in about 5-10% cases, you can find a discordance between the IHC and the PCR or IHC and the further genetic testing. There can be artifacts of fixation. So for immunohistochemistry also, a properly fixed tissue is absolutely essential. Otherwise, there can be interpretational errors and fixation artifacts in the IHC. There can be artifacts of staining and there can be subclones. So, and also post neoadjuvant, there can be a loss of MSH6 that is documented. So once we see, I've mentioned that MSI testing or MMR testing by IHC is a screening test. What we do is, if there is a patient with colorectal cancer, or all patients with colorectal cancer should undergo MMR IHC. If there is a loss of MSH2, MSH6, isolated loss of MSH6 and isolated loss of PMS2. So all these patients go for genetic testing. So one of the things that I missed telling is that broadly you have molecularly two types of cancers. So there are further types, but broadly you have this conventional, and the other one is the one which is MSI high cancers. In the MSI high cancers, about 3% would be genetic, which are associated, which lead to Lynch syndrome, whereas about 12%, 12 to 15% are actually sporadic. So there you don't have a germline mutation, but there is a epigenetic silencing because of promoter hypermethylation of MLH1 gene. So most of the times the gene which is implicated in sporadic MSI high is the MLH1 gene. And if the gene which is involved is MSH2, MSH6 or PMS2, then it is likely to be genetic. So in sporadic cases, it is usually the MLH1 which is silenced because of promoter hypermethylation of MLH1 gene. So this is what helps us in screening it. If in the MMR-IHC, if it is apart from MLH1, if it is MSH2, PMS2 or MSH6 which is involved, then you can straight away refer to genetic counseling, and then there is a germline testing can be done, and this patient can be referred to genetic germline testing for Lynch syndrome should be done. But if there is only loss of MLH1, then BRAF testing has to be done, because most of the sporadic causes of MSI high are because of BRAF mutations. So BRAF mutations lead to a progressive hypermethylation of the promoters of MLH1 gene and its silencing. So all cases where you have MLH1 loss, BRAF mutation testing should be done, because if it is BRAF testing, then it is a sporadic MSI high colorectal cancer and not a Lynch syndrome. So those BRAF mutation testing, there is no further testing required, germline testing required. If there a BRAF testing is not there, I mean, if it is wild type, then you do the second type of testing for MLH1, that is the MLH1 promoter hypermethylation. So BRAF testing and MLH1 promoter hypermethylation will tell you whether this is sporadic MLH1 loss or there is an actual germline mutation. So if there is MLH1 promoter hypermethylation, that also means that there is epigenetic silencing and no testing is required. Whereas if it is MLH1 is also not there, then this person goes for genetic counseling. So this is basically how we use this to further whether the patient needs germline testing or whether this person is likely to be sporadic. So the checklist for this is, I think I have already overshot my time. Essentially, the checklist for core data items is that we need to have all these parameters in before we release the report. The specimen, the site of tumor, what is the diameter of the tumor, what is its distance to the resection margins, tumor perforation, the grade of TME, the histologic type, TNM staging, resection margins, histologic grade, presence of venous invasion, especially extramural venous invasion, PNI, tumor regression if neoadjuvant therapy is given, tumor budding, and MMR status. So this checklist every pathologist should use, and surgeons should also check whether all the information is there or not. So this was in the resection specimen, and last but not the least, in the metastatic setting, we get tissues to see whether we can do further testing to see whether this patient is eligible for some targeted therapy or not. So in the metastatic setting, we do testing for all RAS testing, where you want to see whether the patient has KRAS or NRAS or HRAS mutation. If any KRAS or any RAS mutation is there, that patient is not eligible for EGFR therapy. So to select out patients and in the metastatic setting for anti-EGFR, we do all RAS testing and BRAF testing. BRAF testing, as we've seen, is also for not only for detecting whether there is a sporadic MSI high, but also it's a very poor prognostic factor for colorectal cancers. HER2 testing is done to look for if there is HER2 is amplified, then anti-HER2 treatment can be given in a metastatic setting. If MSI high tumor is there, then immunotherapy can be given, in the metastatic setting, usually there is a very low percentage of patients that you will find MSI high. But if it is MSI high, then immunotherapy has a good chance. And now we have also seen that in the neoadjuvant setting, also immunotherapy in a MSI high tumors can show very good response and even complete response, leading to organ preservation. And very rarely you can find NTRK, for which very good anti-NTRK inhibitors are there. So in the metastatic setting, the goal is mainly to look for targeted therapy. In this, usually we do either HER2 immunohistochemistry, MSI immunohistochemistry, or we can do sequencing to identify whether these mutations are present, and then we can choose what targeted therapy is required. So I'm sorry I have overshot my time. So basically, the pathology reporting requires that the clinician sends the right specimen and provides us the complete information, and so that we can provide complete and adequate information. Pathologists should ensure that they incorporate all the core data items. So a checklist helps us. So synoptic reports or checklists, all these templates are available. If your pathologist is not giving you for complete information, you can help them by providing the CAP. They can refer to the CAP protocols, the RCPath data sets, or the ICCR data sets. These provide guidelines on what all, they are like the data sets or the checklists that can help them include all the information. And it is also good for you to refer because they have explanatory notes. So whenever you do not understand any information, you can refer to these to find out what the explanation of these core data items is. And communication with the pathologist is also a key factor. Include them in your multidisciplinary team. And whatever is, there should be a continuous dialogue whatever changes you make or whatever is, if the information they are providing is not adequate, it's important to communicate. So it's not just a report that is generated by the computer. There is a lot of work that is being done behind the scenes. So it's important to communicate, and communication can lead to better service delivery. So thank you for your attention. If there are any questions, if anybody is awake, they can ask questions. Thank you. I'll be happy to answer.
I think thanks, Munita. That was a great talk. I think you delivered it perfectly. I think everyone is stuck, so I can't see any questions coming up here now.
Oh, everybody is sleeping.
They did perfect, doctor. Enjoyed it, and I think probably we've run out of time, and we'll come back for questions later on. Thank you, Munita, for taking time out again.
Thank you. Thank you so much.
There's one question need to know further about T4B. We can take this one.
Okay, I think where is the question? Given. I think Dr. Lala has asked whether he needs to know further about T4B and regarding small bowel involvement.
What is the question? What do you want to know?
I think Dr. Lala wants to know anything more about T4B.
So T4B is when a large bowel is, when a tumor from a large bowel is directly involving a small bowel. So what level of infiltration? Any level of infiltration into the bowel wall, into any layer of the small intestine. Suppose it is the small intestine which is stuck to the colon or sigmoid colon or any part of the colon. Then if any involvement of the wall, serosa, subserosa, muscularis propria, submucosa, or transmural. So any part of the small bowel involvement is T4B. I hope that is what was the question.
I think
What is the sample for MSI testing?
Sample you can use the biopsy or the resection specimen. Biopsies are better fixed, so they show better results. But sometimes you may not have. One of the issues is that sometimes you may not have a proper tissue in that biopsy. Then you can always do it on a resection. So resection and biopsies both have been compared. Both can show equivalent results. But biopsies being small, they tend to be fixed better. So you can do immunohistochemistry either on biopsy or on resection. Post-neoadjuvant specimen, you can have artifactual loss of MSH6, so that can affect interpretation. So preferably in cases where there is neoadjuvant therapy has been given, then a biopsy, pre-therapy biopsy is a better specimen. But biopsies, resections, metastatic site, any tissue is good enough for testing.
So thank you very much, trainees and faculty members, for joining the session.
Take care. Thank you.
Thank you. Thank you so much. Thank you for having me.